Hello, my name is Karen and I would like to present Infant Feeding and Nutrition, the Vomiting Neonate, Complications, Differential Diagnosis and Treatment. Infant feeding and nutrition is a critical component of public health promotion and deserves considerable attention. The World Health Organization and Department of Health and Ageing provide extensive evidence-based guidelines for the value of breastfeeding, express breast milk, and encouraging participation in the Baby-Friendly Hospital Initiative. The health of the adult begins in the womb and continues across the lifespan, and it relies on collaboration at every level. Now, story time. Sam was a healthy premature baby born at 34 weeks. He had an uncomplicated rapid delivery in an obstetric unit in a private hospital under the direction of specialist obstetricians. He was cared for impeccably and placed in a humidicrib for 24 hours with rapid progression to an open crib. Mum was a primigravida who did not want to breastfeed as she wanted to go back to work at her business as soon as possible, so she decided to give formula bottle feeds. Sam had immature suck, swallow, breathe coordination, so a nasogastric tube was inserted and Mum was taught how to provide nasogastric feeds on demand. Sam was very hungry and fed with gusto 10 times per day. Sam also experienced small amounts of reflux during burping. After 1 week, he developed a strong suck and swallow, resulting in removal of the nasogastric tube and commencement of bottle feeds. After a 1-week stay in hospital, Mum was able to take Sam home. Sam continued on formula with gusto, resulting in increasing reflux. So, is this serious? There are many causes of vomiting in neonates. In order to make any diagnosis, it is essential to also consider differential diagnosis prior to forming a high index of suspicion. Sam had gastroesophageal reflux due to an immature esophageal sphincter allowing contents to be burped up out of his mouth. Babies may experience severe reflux resulting in failure to thrive, esophagitis, increased risk of aspiration, recurrent respiratory infections, aspiration pneumonias, cardiorespiratory compromise, and it has even been linked to SIDS. Do not ignore it. Treat it seriously. Simple interventions may prevent the devastating sequelae. Reduce volume of feed, increase number of feeds, slow down, minimise air gulping when feeding, increase time sitting upright after feeds, and never lay a baby flat in bed. Aim for at least a 30-degree head up. 3 weeks later, Mum called the obstetrician to tell him she was at her wit's end, as Sam was now vomiting large amounts and did not seem to be growing much. The private obstetrician decided to readmit the pair to the special care nursery. On assessment, Sam was experiencing projectile vomiting of formula every feed, failure to thrive, and was very hungry. He did not have any lower abdo pain or diarrhea though. On completion of a bottle of formula, the obstetrician palpated deep to the right of the spinal column in the right upper quadrant and felt an olive-type object. What does this indicate? Sam was diagnosed with hypertrophic pyloric stenosis. HPS is a relatively common cause of non-bilious projectile vomiting in 2 per 1,000 neonates. Thickening of the circular pylorus muscle obstructs the duodenum lumen, which contracts with feeding, resulting in forceful expulsion of stomach contents via the immature esophageal sphincter. It is relatively easy to differentiate between HPS and gastroenteritis due to HPS babies are always hungry, have no diarrhea or fever, whereas babies with gastroenteritis refuse feeds, are fussy, have diarrhea and fever. Sam also had blood streaks in his vomitus indicating esophagitis. Sam was found to be decompensating with mild dehydration, malnourished, hypovolemic, hypochloremic metabolic alkalosis, hypoglycemia and hypokalemia. He was also extremely hungry. Prior to feeding or antiemetics were given the obstruction was assessed. Due to the partial obstruction, minimal enteral feeds were commenced with careful assessment of tolerance via aspiration of the nasogastric tube. Despite Sam being in a life-threatening nutritional emergency, he could not even tolerate meth, let alone a proper feed. Sam is experiencing a nutritional emergency requiring rapid administration of high-protein, caloric, nutritional substrates as soon as possible. He is experiencing catabolic starvation due to an inability to tolerate feeds, resulting in projectile vomiting, compensatory hypochloremic alkalosis with ketoacidosis. All infants have little reserves which rapidly disappear, resulting in decompensation. Even in healthy infants, it only takes 4 days for these small reserves to be obliterated in the absence of food. Sam needs fluid resuscitation to correct hypovolemia and hypotension, correction of hypoglycemia and electrolyte disorders, fluid maintenance to correct dehydration over 48 hours, high protein caloric nutritional formula for sustenance and relief of starvation. Clear fluids greater than 24 hours may result in exacerbation of starvation and failure to thrive. Sam was transferred to NICU for neonatal specialist management and one-on-one nursing. He was scheduled for surgery as soon as possible. After the operation, Sam remained stressed. If the neonate looks stressed or in pain, they are. Unfortunately for Sam, everyone assumed that he was in pain from the operation. No one investigated the cause of his pain. They just increased his fentanyl, resulting in masking other signs and symptoms. He experienced high temperatures and fluctuations in consciousness, leading to the impression of sepsis. 2 days later, he had a bowel action, appearing like red currant jelly. What do you think was wrong with him? Sam had ileocholic intussusception requiring air contrast enema correction in NICU. Over the next week, he experienced further abdominal distension. Sam experienced intestinal ischemia reperfusion injury secondary to delayed detection of the intussusception, resulting in necrotizing enterocolitis. He deteriorated rapidly with pain, abdominal distension, abdominal compartment syndrome, metabolic derangement, multi-organ failure, and sepsis. Sam died in NICU at 8 weeks of age. Does anyone still believe that reflux is completely harmless and babies grow out of it? Fortunately, it can be treated and the life-threatening consequences may be avoided. Health promotion and preventative medicine really does begin in the womb and continues across the lifespan. Make sure you lengthen your patient's lifespan in everything you do. Thank you for listening and enjoy the SMAC conference.